Hi everyone, thank you to be here today with us for the lecture Pulpotomy as Permanent Treatment of Irreversible Pulpitis in Mature Molars by Professor Leprince. Professor Leprince, thank you so much to be here today with us.
A pleasure.
Thanks a lot. So to begin, let me introduce you to begin. So you are currently a professor in conservative dentistry and endodontics at UC Louvain in Belgium. You are there the main lecturer in endodontics, cardiology, and conservative dentistry, and advanced biomaterials and biotechnologies. You are also involved in teaching immunology applied to dental disease and biomaterials. You are head of the Adult and Child Dentistry department at Clinique Universitaire Saint-Luc. You are responsible for the postgraduate program in endodontics and conservative dentistry. You are also the author of numerous papers in the best journal in the field and wrote several book chapters dealing with endodontics and dental materials. You received several scientific awards. You are a member at the editorial board of several journals, and you serve also as reviewer for numerous renowned journals in the field. So really, it's a great honor to receive you today. So thanks a lot again.
I would like to say hi to all the colleagues connected today. I'm here today with Julian here, my colleague and PhD student in the group. He's the first author of the paper that we're going to talk about tonight. So we're going to co-chair this session and hopefully answer your questions.
Thanks a lot. So we are here today for around 1 hour and a quarter, made of 50 minutes of lecture. So this lecture is recorded. The lecture is in English, and you will have the subtitles in French. And then we will have a session of question and answer in live with you, Professor Leprince. So you published a study in January 2022. So 4-term pain evolution and treatment success of pulpotomy as irreversible pulpitis, permanent treatment with a non-randomized clinical study. In a nutshell, this study confirms that pulpotomy procedure in teeth with signs and symptoms of irreversible pulpitis is an excellent alternative to root canal treatment. So in a nutshell. And so dear attendees, I would like to know if it's already the case for you. So I will launch some questions, 2 polls, and you can answer directly by clicking on it. So I hope that everybody is ready. So I will start with the first question. So I'll launch the poll. So the first question is, have you already treated an irreversible pulpitis with a pulpotomy? So please answer, and I will close the poll in 10 seconds. So thank you. So I will close the polls in some seconds because some of you are here. Great. So thank you. So let's see the result now. So an interesting result with a majority of no. So did you expect that result, Professor Leprince?
Well, I don't know what to expect in that regard, because in theory it's both, as I will address in the webinar. It's both an old and a new strategy. This strategy has been around for decades actually, but has come back to the current trend more recently. So it's good to see that some people already started using this, but in fact we need probably a little bit more evidence so that we can reach 100%, because it's not yet clear. We have too little clinical study. So in fact, it makes sense to have so far a minority performing this.
Okay, thanks a lot, Professor Leprince. So second question, and then we will launch the webinar. So this is the second question. How often do you have a patient with irreversible pulpitis? So please answer, and I will close in 10 seconds. Okay, thank you. I will close the polls so we can see the result. So let's see the results. So most of you treated irreversible pulpitis quite often. So from your point of view, so what could be the explanation, Professor Leprince?
Well, that is not surprising to me, because well, we have still a high prevalence of caries even in what are called developed countries. This is very often if you work in a clinics with an active emergency department, that makes sense that you probably have that every day, and which is our case. We have multiple cases like this every day, and in a practice it makes sense that you have that several times a week probably. So it is really a question that needs to be asked, because a lot of people are facing this pathology very frequently.
Okay, thanks a lot. So great, it was a very good introduction to our lecture. So now we are ready to launch the webinar. So see you in 50 minutes for the question and answer in live. See you.
See you. Yeah. So we're here today to talk about what I think is a very interesting topic, is the use of pulpotomy as a permanent treatment in irreversible pulpitis in mature molars. I prepared this presentation with my colleague Julian Bokis. I'm Julian Leprince. We recently published a work on this topic, and we would like to share today the results of our work, as well as some thoughts regarding the use of this strategy as a future therapy to be used worldwide. So I could start this presentation by proudly declaring that this strategy is truly the future of endodontics. But honestly, to anyone who has a little bit of insight into the history of endo, that would not sound very true. Indeed, to be honest, pulpotomy is a quite old strategy. Cases like these ones published in the 50s can be found in old papers and textbooks. So this strategy has been around for decades, really. So the question is really what then can be considered the future of endodontics. Where do we stand? So in 2 years ago, during the initial outbreak of the pandemic and the lockdown, we wrote with a colleague a paper really asking this question: what are the important aspects in our work, and what shall we focus on? We shall focus on important things that can be defined on clinical progress, so progress that matter to the patients. So that's called patient-based outcomes. When you look at the literature, and we tried in that paper to quantify the cumulative number of publications dealing with endodontics over the years, and as you can see, it's increasing tremendously. It has accumulated, so the knowledge has accumulated tremendously over the years. And what is really puzzling is try to, as you can see here, superimpose the success rate of endodontic treatments over the same period. And well, then one can see that it's not really a clear pattern, and one may ask where all these publications are really actually leading us. That has been the conclusion made by NG and her group in her paper in 2007, stating that the success rate of root canal treatment has not increased over the last 5 decades, while indeed the scientific production in our discipline has grown quite a lot over the same period. And this is, in my opinion, very well exemplified by this review paper published in 2016. It's a review with, well, I'll say it's been written by some authors that I consider really major players in the game, really respected. I respect them a lot. They're really contributed a lot to increase the scientific knowledge in endodontics. And in the introduction made by these authors, they write that the past couple of decades have witnessed one of the most rapid and extensive technological evolutions in dentistry. So that's very appealing, that's very stimulating. You read further and you see this sentence: this period has presented some remarkable developments of endodontic technologies. So you say, well, okay, I'm going to enjoy this paper a lot, I'm going to learn a lot, and this is going to change my practice. I'm going to learn really new stuff. Let's now consider one example. So they treated in this paper, they covered root canal disinfection, instrumentation, irrigation, imaging, and pulp regeneration. So let's now consider just the case of instrumentation as an example. Regarding root canal instrumentation, the following is written: most current instruments perform well when used judiciously. So the appropriate use of an instrument is really what seems to matter. They also state that shaping alone is not sufficient to reduce microbial microbes load, and that we should irrigate. Well, that's quite well known, and that's not as stimulating as what was expected from the introduction. A few years later, so very recently, Ove Peters, same author, and her colleague, his colleague Anna Arias, published another review on all the future directions and present status of canal shaping. It was just freshly published in International Endodontic Journal, and they once again we can read the following statement: major improvements have been observed over the years. That's without a doubt what we see in our clinical practice, clinical routine. But it is not clear yet if all these improvements are directly translated to an improvement in terms of clinical success. And in the end, it's what really does matter in terms of improving patient care is all these what we call patient-centered outcomes, which are mainly twofold. First, success, and two, tooth survival. So let's take two major works in that regard, and let's compare. First, success. Very recent 2020 published in PLOS ONE randomized clinical trial comparing two groups in terms of the following outcomes: post-op pain and a healing of apical periodontitis. The two groups are first a reciprocating system with obturation with matching taper single cone, and the second group is a classical crown down technique with hand files and lateral compaction filling. The conclusion is that there was no observed significant difference, neither regarding post-op pain nor regarding healing at 12 months. So no difference regardless of which classic or modern techniques you were using. Second outcome, very important to our patients, is the survival. Retrospective study this time, so not as high in terms of level of evidence, but here compensated by an increased sample size, almost 1,000 cases. The outcome was tooth survival, as I mentioned. The two groups, again, classic preparation versus contemporary. Again, the authors report no significant differences between classic and contemporary preparation strategies in terms of tooth survival, and the average follow-up time was more than 6 years. So that leaves us a little bit questioning the importance of all the research that has been done regarding instrumentation when we don't see that we are able to identify any progress regarding patient-centered outcomes, regarding success or survival of the treatment. And that can also be seen regarding the number of papers published yearly related to endo and nickel titanium instruments, where we see a drop in the last few years. So this topic has received a lot of attention in the 90s, but as we just saw, the winds might be turning a little bit. And this is possibly due to the fact that we were not able clinically to identify difference in terms of clinical outcome, and that's some part of the conclusions that we made in our letter to the editor published 2 years ago, that possibly one way to go in the future is more related to host-related variable, which have barely been investigated, and there's a reason for that. It's much harder. I find it quite difficult to investigate that aspect. And in this prospect, we should focus probably more on patient-centered outcomes and public health visions or strategies. So possibly the way to go is to go back to the foundations of endodontics, which is related to the biology, periapical biology, pulp biology. And as we can observe in the last few years, we have seen an interesting increase in the publications related to endodontics and cells, immune cells, stem cells, and mediators. So we're getting back to biology, and that brings us back to the topic of today, the pulpotomy as permanent treatment, and our recent publication, short-term pain evaluation and treatment success of pulpotomy in permanent molars. We designed a clinical trial that was non-randomized, and the reason for that will be addressed a little bit further, because we wanted to take into account the experience of the practitioners in a strategy that is sometimes referred to as easier or more accessible to practitioners. But before jumping into the clinical trial itself, let me address some important aspects of this strategy, the pulpotomy, in terms of indications, rationale, and progress. So let's start first about the progress and the evolution of materials. So in the introduction, I shortly mentioned that these strategies of pulpotomy have been around for decades. The first reported cases are more than 100 years old. As you can see here on this timeline, it's been evaluated. There's been an evolution over the years between the use of formocresol, calcium hydroxide, zinc oxide, eugenol, and more recently tricalcium silicates. And that's one of the reasons that these strategies are coming back to the forefront, is because these evolutions of materials have made these strategies more predictable, and so more potentially attractive in the future. So this has been published in 2007, and this is a histological evaluation of the outcomes of pulp capping with MTA on the left and dical, so calcium hydroxide material on the right hand side. And what we can see, and this is really classic work now, is that MTA or tricalcium silicate materials are able to generate the formation of a complete dentin bridge, or shall I say mineral barrier, whereas the dical was shown to induce the formation of an incomplete mineral barrier with what is sometimes referred to as tunnel defects, and also a major difference in terms of the persistence of the presence of inflammation in the pulp tissue, where there's almost no inflammation remaining in the pulp underneath tricalcium silicate cements, where there is inflammation present under the dical or calcium hydroxide material. So the first reason why these strategies are coming back have been coming back over the last few years is the improvement of materials leading to superior histological outcomes. The second reason is that there's also a clear advantage that has been demonstrated clinically with improved success rates in the treatment of exposed pulps. And most of the literature currently available in that respect is related to direct pulp capping. And for example, there's the paper by Hilton and collaborators very nicely show the significant improvement in success rates in a practice-based research network in the US. So we have better tissue outcome and better clinical outcomes when the pulp is exposed. So that gives us more confidence in the use of these materials with regards to the pulp tissue. Second evolution is not related to materials, but to the knowledge acquired over the last few years in pulp biology. The first really category, I would say, of progress that we've made was provided by the very nice cases of the colleagues who produced histology. Here an example by Domenico Ricucci with very beautiful, very well-known work in histology, and we can see here a very interesting case with the deep caries with the production of tertiary dentin, but also an area of necrosis in the medial pulm horn, and the fact that there's here a microabscess and the presence of bacteria, signs the irreversibility at the tissue level. It's not necessarily the case clinically, but here that's really the sign, according to the authors, of an irreversible case. What we see, what else do we see on these, this specific case and many others, is a gradient of inflammation. That's interesting. We tried clinically to characterize a case as reversible or irreversible, but at the tissue level, we see really not an all or nothing situation, but more of a gradient, starting from the area of necrosis, where we have bacteria, then intense inflammation, and the further you go from this area, and the more likely you are to reach a tissue without any inflammation, so a sound tissue. So the knowledge in histology gives us also more confidence in the strategy consisting of an elimination of the upper part of the pulp, where there's necrosis, infection, and inflammation, and a preservation of the lower part of the pulp in the root canals, where we can hope to reach a sound pulp tissue. Another interesting area where progress has been made over the last few years is molecular diagnosis, as was here described and nicely reviewed by a friend of mine, Dan Retschelberg from Zurich, where he explains how we could use and take advantage of the quantification of all these inflammatory mediators to try and diagnose more accurately the state of the pulp. Well, as a matter of fact, also of periapical tissues. So here, the idea would be either when accessing the pulp or without accessing the pulp, to try and sample a little bit of either periapical fluid, pulpal blood, fluid from the gingiva, or dentinal fluid, using some absorbing papers and trying to quantify some of these biologic mediators. An example of one of the first papers that has done just that, published by Matt Sender, was the quantification of MMP9 as a marker, as a probe to try to differentiate a pulpitis from a healthy pulp without any access to the pulp tissue itself. So we can see here there's some clear differences that have been highlighted, but it doesn't seem to work on all the cases. So there's still progress to be made, but with these different fields of different research directions, we can really say that we have improved tremendously our knowledge in pulp biology over the last few years. So progress has been roughly and quickly covered. So that gets us to the rationale of performing a pulpotomy on irreversibly inflamed molars. The rationale that we often hear when talking about this clinical treatment is that it's more conservative. It allows us to preserve an immunocompetent tissue, so a best filling material would be the pulp itself. It's also said to be cheaper, to be potentially equally efficient, and we'll get to that later, to be quicker and easier technique as compared to the standard root canal treatment. So we'll see at the end of this presentation how our work and the other works available allow us to conclude on all these potential for this strategy. So let's now just briefly talk about the indications, which is a very important aspect of opting for this strategy. In the IEJ guidelines and the literature mostly published by Lars Bjørndal and his colleagues, there's a clear distinction that has been made between deep and extremely deep caries. And in that literature, really clearly, that really draws the line between the pulp preservation, so vital pulp therapies, which require the presence of a separation, of dentin separation between the lesion and the pulp, as compared to extremely deep caries, where the caries and the bacteria penetrate the entire thickness of the dentin. When we look at their data again regarding histology, we see that there is a production of tertiary dentin on the left in deep lesions, and the bacteria have not reached the pulp tissue, whereas on the right-hand side, in extremely deep lesions, there's a very high probability for bacteria to have actually reached the pulp. If we take a closer look at higher magnification, there's also a difference in terms of inflammation, where on the left-hand side we see little inflammation, whereas on the right-hand side, where bacteria have penetrated the pulp, we see a very, very intense inflammatory reaction. This has led, well, the ESC to write a position statement with all these great colleagues here, and recommendation in terms of management of these deep caries and the exposed pulp following caries development. The conclusion is the following. One of the conclusions is that caries exposure shall be avoided at all costs and treated with partial excavation, but in cases where extremely deep caries are observed, are present, we should go for a pulpotomy. They make a specific sentence regarding irreversible pulpitis, because most of the guidelines is really focusing on reversible cases. In terms of irreversible cases, the recommendation in theory is more the pulpectomy. But they state, and that's the topic of today, that full pulpotomy to the root canal entrance may be successful, but that better long-term prospective randomized data are required before this becomes the treatment of choice. And our intention with this work was to contribute to increase the knowledge and the data regarding this kind of treatments. So that brings me to the clinical trial itself, and we're going to cover our objectives and then our results. So the objectives of this study was to evaluate two things, two outcomes. First, the short-term pain evolution, and second, the treatment success when performing full pulpotomy as permanent treatment of the irreversible pulpitis. Why did we introduce these two objectives? That's very important when you consider as inclusion criteria pain and irreversible pulpitis as the key targets. It's very important to evaluate short-term relief for our patients. It's not sufficient just to evaluate the long-term outcome. So we had these two objectives in mind, and we thought about the design. And what we we often thought about was that this strategy is supposed to be something that is more accessible. It has been alluded to in the rationale. It's a strategy that should be easier and faster. So we thought this is a strategy that should not be only focused on, only directed to specialists, but it should be practiced. Should be possible to recommend that to all practitioners. So our design was therefore non-randomized with two groups. The test group was a pulpotomy performed by non-specialist junior practitioners. so less than 3 years residence, in our dental hospital, university or hospital. And this group was compared to what often the professional organizations consider as the gold standard, or at least the best available treatment. It would be specialized endodontists working in private practice. So that was our control group. We had several inclusion criteria, mostly the importance of the diagnosis of irreversible pulpitis, being spontaneous pain, radiating pain that lingers after removal of cold stimulus. We worked only on mature molars. We can discuss that afterwards, but this was a decision mostly based on anatomical characteristics of these teeth and the high prevalence of pulpitis in molars, and we worked only with adult patients. This phase of the inclusion is very important, since, as mentioned here by renowned colleagues, the initial phase of treating endo pain patient is diagnosis. So we put a lot of emphasis on diagnosing properly irreversible pulpitis. We then introduced several exclusion criteria. You can read as well as me all the different symptoms that all the eligibility and non-eligibility criteria that we included here, which are relatively classical. But what is important is also not only the pre-op, but the operative criteria. When we open when we access the pulp chamber, we excluded the presence of partial necrosis, total necrosis, as was the case here in the lower case, for example, where we can see a vital pulp in the mesial root canals, but necrotic pulp in the distal. The upper image picture of the tooth number 37 is an example of what our goal was after the pulpotomy, is to obtain a very nice hemostasis after pulpotomy. We also excluded cases for which we could not get hemostasis, and cases for which we needed to perform an intrapulpal injection in patients with a lot of pain. Also, these are important aspects to discuss possibly after the webinar. In terms of timeline, so we recorded recorded the first outcome was short-term pain evolution. It was recorded based on a scale, a Heft-Parker scale, which was given to the patient with, as you can see here on the screen, the possibility to describe the intensity of pain that he or she was experiencing, and we would then transform that into numbers to then quantify pain and analyze the data. So that was the first objective: short-term pain evolution, pre-op, 24 hours and 7 days after patient inclusion. We then evaluated the treatment success, which was evaluated after 1 year and further. The idea was to discriminate between clinical success, radiographic success, and the combination of both the global treatment success. So clinical success was considered as the absence of re-intervention, extraction, or the presence of signs or symptoms, such as pain or sinus tract or swelling. Radiographic success was evaluated using the periapical index with the evaluation of the X-rays independently by two observers who were not involved in the study, in the clinical cases. We used the periapical index of 1 and 2 as healthy, and then we evaluated the success as the persistence of healthy periapical index, a decrease in periapical index for PAI of more or equal to 3, and or a stabilization of periapical index if the initial ranking rating was 3. We performed a kappa evaluation of the two observers, and we reached a kappa of 0.72, which was satisfactory. It's important to notice also that any clinical or X-ray failure during the follow-up period were classified as a treatment failure. So now let's move on to the results. Here, the flow chart of our study, which is interesting in terms of inclusion. For example, you can notice here on the left-hand side that we excluded 13 patients based on the exclusion criteria. And this really is something important to consider in terms of which cases are potentially eligible for this procedure. There are cases, so this is not a procedure that you can apply for any case of irreversible pulpitis. As you can see here, some cases need to be excluded. We can see also that we've had a few dropouts before the final long-term evaluation, but all the cases could be evaluated in terms of short-term treatment, pain measurements. So let's get to this short-term pain evaluation. So let me remind you, we evaluated pre-op pain by phone call at 24 hours and 7 days, the evolution of pain with time and with treatment group. First thing you can observe is the lack of significant difference between the test and the control group in the pre-op situation. So that's something important because we want obviously to compare how it evolves with time. Second aspect is that we observed a significant decrease of the pain level at each time point, but without any significant difference between both groups at each time point. So that's for us an important and short-term information is that in terms of very important patient-centered outcome, the management of pain seems to be as efficient in the test group as it was in the control group. The second phase of the study was the evaluation of the treatment success. We had a follow-up percentage of between 75 and 80% for both groups. The mean and the median, which is quite satisfactory, as I will mention later on, is more than 2 years, 2 years or more. And we have made the following conclusions. First, regarding clinical success, we didn't notice any significant difference between the test group and the control group. Regarding radiographic success, on the contrary, we noticed a significant difference between the test group and the control group in favor of the test group, which means that the pulpotomy in that respect, regarding that outcome, performed better. Globally, treatment success was comparable between both groups without any significant difference between the test and the control group. So that's also very promising in terms of outcome. So we have both short-term and longer-term outcome, which didn't seem to be different from the test to the control group. That leads us also to some perspectives which we would like to share with you. And the first one is the significant difference that we observe regarding radiographic success. Here we would like to share one of the cases from the study where we could, which was rated as PAI 3 pre-op, and that evolved after 20 months to PAI 2, sorry, as evaluated by our two colleagues. And this tends to show that there can be some degree of periapical involvement that can be resolved or healed after this kind of procedure without any without accessing the root canal system. A second interesting perspective is that we had the opportunity to perform a histological analysis on one of the cases. The tooth, which was a upper second molar, was extracted for restorative reasons. It was fractured and could not be restored, and therefore it was decided to extract. And we had the opportunity to work with Domenico Ricucci to perform histology, and I thank him again for his help on this case. And as you can see here on the lower part of the slide, you can see his work and the sections showing the persistence of a healthy pulp without any signs of inflammation, with odontoblast, with an intact odontoblast layer, and that is the case almost, well, a little bit more than it was 45 months after the treatment was performed. So it shows that at a relatively long term, we had the opportunity to prove that the root canal was not empty, but was still occupied by a healthy pulp tissue. The final perspective that we want to share with you is the comparison with the otherwise available data on the topic of pulpotomy on irreversible pulpitis. Our work here is in red, and you can see all the works that we know of that were dealing with the same topic. First important thing to consider is that there is a relatively low number of studies on the topic. Six of these, six studies available, six patient databases, among which 4 have only 12 months of mean follow-up. So clearly, as stated in the ESC position statement, we need more long-term data. And here we hope to have contributed to improve the knowledge in terms of evaluating this procedure with a longer follow-up period. This is still much less than the first study, where they performed, they included a large number of cases with a long follow-up. Now, in the last publication, 5 years recall, where we can see that the global success is in the same range. Very importantly, also, it's important to in our regard to include pain analysis to be able to validate, to confirm that we can provide pain relief to our patients. And it's important also to include a control group with regard to the usual strategy that was that is recommended so far, which is the root canal treatment. So by that, we hope to have contributed to increase the knowledge and the confidence in this kind of strategy. So a little bit of discussion. Let me go back to the rationale for these strategies that I mentioned earlier. So first, is this strategy really more conservative? Well, yes, definitely, because we were able, by one of our cases, but it's clearly becoming more obvious that it's possible a few years after the procedure to find a healthy pulp in these root canals, provided that the diagnosis and the inclusion criteria were properly respected. And that reminds me of the trend, the current trend going on, that we try to spend a lot of money on tissue regeneration. We are in the era of tissue regeneration, and which I find really very exciting and interesting. But maybe we should start first preserving and trying to save the tissue before trying to replace it with very complicated strategies. That's a little bit like what we're doing on our good old Earth, where we have people who are considering traveling to Mars and creating new forms of habitat over there, whereas we could just simply preserve what we have back home. It's a little bit a similar situation as what we have with the pulp. The second rationale was that these treatments are potentially cheaper, and that has been also mentioned in the very recent paper dealing with health economic evaluation of endotherapies, and clearly stating that maintaining pulp vitality is preferable over root canal treatment, if possible, of course, when it comes to cost effectiveness. So these treatments are more cost effective than the standard root canal treatment. Of course, this is a public health vision. It remains to be determined how to charge the patients for such a strategy. We can talk about that later on together, but this will probably depend on how each country will and their respective healthcare systems are going to cover the costs of these various procedures. Third aspect is the efficiency, and we have shown, and others as well, that this procedure can be equally efficient or equally effective, may I say, as compared to root canal treatment. This is clearly an interesting perspective, but it's even more interesting when considering that the root canal treatment, so the standard procedure, remains a possibility in case of the failure of the procedure. So it's really complementary, and it's still possible to perform the root canal treatment if this strategy, well, if this procedure fails. Last aspect is the quick and easy. Is it quicker? Yes, it is. It's probably twice quicker. We only need one appointment, the emergency appointment, and it's been described as probably twice shorter in terms of time spent on the dental chair. Is it easier? Well, we actually doubt it. It has been discussed in several conferences that we have been attending to. It's not such an easy procedure. And we're going to illustrate this aspect by a clinical case. This kind of treatment requires quite a lot of care when performing the pulpotomy. Here, a case performed by our colleague Valentin Michaud, who we thank for these beautiful illustrations. Deep, extremely deep caries, pulp irreversibly inflamed, spontaneous pain. So we combine here a radiographic indication and a clinical indication. The enamel was removed to gain access to the carious tissue. Here we have access to the soft dentin. Then we finalized the enamel preparation to really have better access to the soft dentin that you can see here probed in order to remove that. And we need to work in the exact same way as we would in case of partial excavation. It means that we go from the outer parts that are highly contaminated to the inner part. So we work step by step, progressively remove the outer part. Then we change burrs. We use the round burrs to now excavate the soft dentin. Here, the situation where all the surrounding dentin has been removed, and then we go down to the areas next to the pulp. So step by step. Here you can see we are getting closer, and when he thought he would be getting to the pulp, well, he will now switch to an additional step of disinfection using hypochlorite, sodium hypochlorite, to disinfect the field and try to be as clean as possible. Here we see already pulp horn exposed, and then we move on to the pulpotomy itself. So we're going to perform the access cavity, starting from the pulp horn, going to the rest of the pulp chamber. Here it's important to confirm the diagnosis. We should observe pulp bleeding, of course, because we are here in irreversible pulpitis at the tissue level. Here you see bleeding coming out of at least one of the canals. So we go ahead and we complete the pulpotomy until we can have the complete elimination of the pulp in the chamber. Here is not complete yet. And then we perform hemostasis. Here we work with cotton pellets, sterile cotton pellets, and saline. There's also a discussion that can be done regarding the fact that we should or should not use sodium hypochlorite or should use saline. Here we use saline. Here we can see a beautiful hemostasis of all the root canals, following which we will go ahead, confirm inclusion of the case, and perform the pulp capping itself using the tricalcium silicate cement, here biodentin. Now it is going to be placed very carefully on each of the root canal entrances. So here we're going to accelerate a little bit of the video. The pulp is capped. Here we go. And then there's a waiting time for to let the material settle and set. A little bit of patience. We're getting there. So this movement to use the specific rheological properties. Now here the material is set. We can remove the excess. And here our colleague chose to place a glass ionomer cement on top before being able to talk about future restorative options with the patient. So this is the final situation before placement of the glass ionomer. You can see on the left side the biodentin going down to the root canal entrance and covered by the more radio-opaque material. So that gets us to the conclusions of this work. That should be considered within the limitations, because no work is perfect. We hope we contributed to demonstrate that, to confirm that the pulpotomy is an acceptable and more conservative permanent treatment option for irreversible pulpitis in mature molars. As I already mentioned, reintervention with gold standard procedure, root canal treatment, is still possible in case of failure. This data adds to the existing literature, which is not very profuse at the moment, to support that the fact that the pulpotomy as a permanent treatment could be considered as a first-line treatment. There are biological benefits, and this will probably change the way we consider this procedure. In the good old days, it was rather considered as a way to avoid a difficult treatment, and nowadays it's more considered potentially as a more biologically compatible strategy that resonates with the tissue preservation that is one of the priorities of modern dentistry. We hope also to have demonstrated that it could be applied by a larger population of dentists, because we took into account experience of the practitioners, of course, provided that the strict inclusion criteria, exclusion criteria, and the rigorous clinical protocol are respected. This does not mean that it can be done without any guidelines. Finally, we think it requires a different mindset, probably a little bit more explanations regarding informed consent of this relatively with this procedure with so far limited number of clinical papers. It requires good communication with the patient, and in our case, it was really interesting to have a very clear and rigorous follow-up with phone calls at the key periods, 1 day and 1 week. So ideally, of course, these findings should be confirmed by a multicentric a practice-based study with an increased sample size, but it seems to be a very promising procedure within the limitations that we highlighted today. So we'd like, Julian and I, we would like to thank you for participating, for listening. We hope you found it interesting. We are part of a research group that is called the Dream Team. We do research, we do clinics, and we do teaching, and we hope to meet you again in the future.
Thank you, Professor Leprince, for your highly illustrated lectures. Thank you, Dr. Bokis, for the study also. It was really interesting to explore pulpotomy, and notice that in your study, pulpotomy were done by non-specialized junior practitioners. So it demonstrates that pulpotomy is an accessible and doable procedure by a large audience of dentists. So thanks a lot. We will go through the question and answer now. So let's see the question. Let's see the question. I think the question just arrived. So first question, Professor Leprince. Could you please explain the step of the pulpotomy, please?
How to do it? Is it
just step of pulpotomy.
Step of pulpotomy. Well, that's illustrated by the video itself, but let me specify maybe the most important part of the procedure is first probably the inclusion criteria. So that's something that Julian and I we want to stress, is that this study is really valid within the limitations that we have determined. So we can't generalize beyond the inclusion criteria that we have defined here. So second, as far as the procedure itself, this has been highlighted in the video that we need really to be doing that step by step with a good isolation, rubber dam first. The second part would be really to carefully remove all the infected dentin, so all the carious tissue that is going to be removed prior to entering the pulp. The third step is the removal of the inflamed pulp. So we are using in general a burr on high speed and with irrigation to cut properly the pulp. And then the final important part is hemostasis. So we need to make sure that the pulp is not bleeding profusely before placing the pulp capping material. So these are the important steps to respect for this procedure.
Thanks a lot. Second question is why hemostasis is a key in pulpotomy?
This is a good question because we try to discuss that also in the paper. Classically, in the literature dealing with direct pulp capping, it has been described as an important factor to be able to perform a direct pulp capping. This is not necessarily the same here in when performing pulpotomy, but this is at the moment all we have to evaluate visually the level of inflammation. So we try to we used bleeding as an indicator of tissue inflammation. So we consider a pulp tissue that is still bleeding after several minutes of compression, an inflamed tissue that cannot be capped. But that's why we mentioned in the presentation that more modern and accurate diagnosis systems need to be developed for this procedure, such as those that are recommended in the paper by Dan Retchenberg that I mentioned. So this is called molecular diagnosis, and this needs to be further developed in the future so that we can really, in a more scientific way, determine that the tissue that is left behind is really a sound tissue.
Okay. Another question is, how many sessions do you recommend for doing the final restoration?
How many? Sorry, I didn't get that.
How many sessions do you recommend for the final restoration?
Oh, okay. So that depends how the initial procedure, first procedure is performed, is whether you use temporary material or directly a permanent material on top. But apart from that, probably 2 sessions is what is the best. So the first session would be the pulpotomy itself with the tricalcium silicate on top. And then, as you notice, we think that the follow-up is important. So we recommend to do a proper follow-up of pain on the short term. And provided that this is good, then we can go ahead and place the permanent restoration on top. So probably the usual timing between an endodontic treatment and the final restoration would be the same for here for the pulpotomy. Within a month, it should be. It's usually what is considered as a good interval. More than that, you increase the risk of failure due to restoration.
Okay. Okay. What is the difference between a pulpotomy and a pulpectomy?
Well, the classic difference is that pulpotomy is the removal of the pulp in the pulp chamber, whereas the pulpectomy is the removal of all the pulp tissue down to the apex. this really well, this is the classical definition, and this actually is one of the reasons why we chose molars for this clinical study, is that the limits, the anatomy of these molars enables to really easily locate the end of pulpotomy and beginning of pulpectomy is the root canal entrances. If you work on a single rooted, well, single canal, a tooth with a single root canal, then there's no exact location inside the tooth. So it's more a matter of try to identify the limit of the cementum-enamel junction. So yeah, it's sometimes more difficult to locate in single rooted teeth. I can't hear you. I don't know if you're...
Yes.
Yeah.
Sorry. Can this procedure be done in premolars or anterior teeth?
Well, that's a good follow-up to what I just explained, is that, in fact, there's no reason theoretically why these results could not be extrapolated to other tooth types, except the one good reason is that we have no data confirming that. So we are assuming that biologically this could be extrapolated to other teeth, but I have no data to prove that. And I doubt that there are data available on large databases that currently confirm that. So as always, we need to wait for actual data to be able to extrapolate that to other tooth types. And I can also add that for regular root canal treatments, it's not as simple to generalize the success rates. We know that it's different from molars to premolars to incisors to canines. So I would be careful to extrapolate these results to other tooth types before it's actually investigated. But the good thing is that in terms of prevalence, well, molars are the most frequently affected teeth. So these are the teeth that we most often will treat with such procedures. So that's already a majority of the cases that are taken care of.
Okay, great. Is the age a key criteria for pulpotomy? Age of patient, I mean.
Yeah. Practitioner, I don't know, but possibly. If the practitioner is too old, probably it's a problem. But but for the patient, we don't have the data either. We analyze that, and we have no evidence that it's actually an important criteria. But again, as we mentioned in the paper and the presentation, the sample size we have is too low to be able to really prove that it's actually not an important factor. This needs to be verified at really larger populations with a well-balanced sample between all the age groups. But this has been a frequent question for vital pulp therapy, and the short response is we don't really know if it's really an important aspect. And I think this is in accordance with other papers, that so far we have no proof that this actually matters. The only aspect is the smaller the pulp tissue, which is something that we observe with age of the patients. We have trouble sometimes to actually visualize and evaluate the level of inflammation, of health of the pulp, because the pulp is so small. So that may be a practical difficulty that I can mention.
Thanks a lot. And maybe I think the last question, how do you explain the procedure to the patient?
Oh, that's a good question, an important one. So far we try to be as transparent as possible. During our study, well, it was an informed consent, so patients needed to receive the information and sign a document that was agreeing that they would participate in the study and understood the risks. So now we would, after this this work was conducted, we tend to propose these options to patients, and it's important to explain the risks. So first, we would say that short-term pain management is the same between the classical procedure and this new procedure. So that's an important fact, that pain will be managed as efficiently as it was with the classic standard procedure. Second, that these treatments need to be monitored, and that's also very important. It is the case for, should be the case for all treatments in dentistry, but here it's important that patients understand that follow-up is an important aspect. So we can we have also that is important. And the third part is the fact that we need to consider, or to be really aware and explain to the patients that this is very different than the classical root canal treatments, because in contradiction with the root canal treatment, here re-intervention is possible. So if there's a failure of this procedure, the root canal treatment can still be performed. So this will be a new possibility. And so the decision is probably most often a clinical decision when the pain is present, and it's throbbing, and it's most of the failures we had was actually an inflammation in the root. So when we needed to go back into the root canal, there was profound bleeding, so a sign of radicular pulp inflammation, root pulp inflammation. So follow-up is important, and let the patient know that it needs to be followed up very, very carefully. And if in case of actual failure, then re-intervention will be performed, and we will go back to the standard procedure. So that's, I hope this responds to the colleagues' question.
Thanks a lot. I will take another just last question. And how can I verify if the pulp is still vital after pulpotomy?
So that's also a usual question. That's I would say it's only important from a scientific perspective. If that's we were interested in that because we published in the paper the histology of one of the cases 4 years later, and to our knowledge, this is probably the case with the longest follow-up period that we have available with histology. There are maybe others, but not that I know of. So this is a proof of concept that the pulp, provided that you follow the procedure that we recommend, can stay alive and healthy. So it can be the case, but there's no way of proving that this is the case on all our successful cases. We can't prove that. But that's why monitoring is important. But that's the same in the situation of root canal treatments. How can you prove that there's actually no bacteria left in your canals? It's not possible to prove it. Nobody's going back in there and doing bacterial samplings and analysis. It isn't the same for many questions. So that's why we need well-designed clinical data with sufficient patient number and control groups to be able to know that in the long term, it's not degrading, the situation is not degrading, and patients are not developing infections. So I would say at this point, it doesn't matter to patients so much. This is a difference between patient-centered outcomes and scientist-based outcomes or clinician-based outcomes. To patients, we have proven that we manage the pain and there's no periapical lesions in the not more than the control groups, and this is in accordance with the other papers published. So I wouldn't say it matters too much.
So thanks a lot. Thanks a lot for all the questions. Thanks a lot, Professor Leprince. Thank you for attending this session. To everyone, you will receive the replay by email. And if you have any question, please feel free to keep in touch with us. So yes, thank you so much, and stay tuned for the next webinar. Thanks a lot.
Pleasure. Take care, everyone. Bye.
Bye. Thanks.